Hello everyone, I am myself Dr. 𝗧𝐼𝐻𝐫𝐢𝐚. I am the General Medicine Educator. So I welcome you all to this daily quiz discussion on my Telegram channel, that is Medicine Made Easy by Dr. 𝗧𝐼𝐻𝐫𝐢𝐚. So today I'll be discussing the questions of the Medicine Challenge Day 8. So the first question in the quiz is, the C wave in the JVP is due to atrial contraction, atrial relaxation, tricuspid valve bulge, then the early ventricular filling. So the C wave, it is due to the bulging of the tricuspid valve, and the C wave in the JVP, it corresponds to the isovolumetric contraction phase of the cardiac cycle, right? Whereas the atrial contraction, this will give rise to the A wave in the JVP, and atrial relaxation, this will corresponds to X wave in the JVP, and early ventricular filling, which is nothing but your atrial emptying, so that will corresponds to your Y wave in the JVP. So the answer in this question is the tricuspid valve bulge. Now let me go on to the next question. So A wave in the JVP represents the passive atrial filling, then right atrial contraction, the ventricular filling, the ventricular relaxation. So A wave in the JVP, it represents the atrial contraction. So now if you see the waves of the JVP, so this will be the waves of the JVP. So what do they represent is A, C, X, V and Y wave. So out of which your A, C and V, they represent that the pressure in the atria is increased, and during X and Y, they represent that the pressure within the atria is decreased. So A wave in the JVP, it represents the atrial contraction, and this A wave, it reflects the right atrial pre-systolic contraction, right? It represents the right atrial pre-systolic contraction. So during which phase of the cardiac cycle you will have this particular A wave is, A wave, it corresponds to the second rapid filling of the cardiac cycle, okay? So which is nothing but the later part of the diastole, which is also considered as the pre-systolic contraction, okay? So the answer is the right atrial contraction. Next question. In patients of lung cancer with full neck veins and low blood pressure, which of the following is incorrect? The electrical alternance, low voltage ECG, prominent Y wave, absence of Kussmaul sign. Okay. So in a case of lung cancer, why there should be full neck veins and why there should be low blood pressure? These patients with bronchogenic carcinoma, they are associated with the development of one important complication, that is the cardiac tamponade. Right, one important complication, that is cardiac tamponade. So this particular cardiac tamponade, it is the one where you will have the electrical alternance, you will also have low voltage ECG, and the Kussmaul sign is absent in patients with the cardiac tamponade. And in case of your cardiac tamponade, you don't have the prominent Y wave. So what will be there in cardiac tamponade is, you will have prominent X wave and there will be absent Y wave, right? There will be absent Y wave, okay? So the atrial emptying will not be there in patients with the cardiac tamponade because of the diastolic collapse of the right ventricle. That is the reason why in case of cardiac tamponade, you don't have the Y wave. So prominent Y descent, it is an incorrect statement, okay? Next question. So in JVP, Y descent is absent and X wave is prominent. So what does this suggest? The options are the restrictive cardiomyopathy, cardiac tamponade, constrictive pericarditis, right ventricular failure. So it is like similar to that of your previous question. Y wave is absent and X wave is prominent. That is seen in patients with the cardiac tamponade. So let me tell you some important points of cardiac tamponade. The patients with cardiac tamponade, they present with sudden onset dyspnea, right? And they have a characteristic pulse. This is called as the pulsus paradoxus, right? And in the JVP, very important point is the Kussmaul sign is absent, right? And these patients with the cardiac tamponade, they will have the hypotension, right? And the neck veins, they are distended, right? And the heart sounds will be like muffled heart sounds. So these three together, we consider it as the Beck's triad, right? We consider it as Beck's triad. Okay, so that is the fourth question. Then next question, the internal jugular vein pressure determines the pressure of, see, it determines the pressure of right atrium, right ventricle, left atrium, and as well as left ventricle. So it determines the pressure of the right atrium. So how much will be the normal JVP? The normal JVP, it is around 5 to 8 centimeters of water above the right atrium. Okay, and whereas you take the left atrial pressure, it is represented by the pulmonary capillary wedge pressure. The normal value is 6 to 12 millimeters of mercury, right? And how will you measure this pulmonary capillary wedge pressure? This pulmonary capillary wedge pressure, right, it is determined by Swan-Ganz catheter. Right, it is determined by Swan-Ganz catheter. So that is about your left atrial pressure. Next question. 𝐾𝐽 wave is seen in the atrial fibrillation, complete heart block, ventricular fibrillation, Mobitz type 1 heart block. So in patients with atrial fibrillation, the A wave is absent. Right, the A wave is absent in patients with the atrial fibrillation. And in case of the complete heart block, you have the presence of the 𝐾𝐽 wave. So 𝐾𝐽 wave in the complete heart block represents increase in the right atrial pressure, right, more than 20 millimeters of mercury. And what are the other conditions where you can have 𝐾𝐽 wave is, see, in case of complete heart block, the type of the 𝐾𝐽 wave that you will have is the irregular 𝐾𝐽 wave, right? Whereas the regular 𝐾𝐽 wave, you see that in case of the junctional rhythms, right? In case of junctional rhythm, you have the presence of the regular 𝐾𝐽 wave. Okay, so that is about, so 𝐾𝐽 wave is seen in the complete heart block. Next question. A wave in JVP is absent in the atrial fibrillation, complete heart block, tricuspid regurgitation, then complete heart block. Okay, so the A wave in JVP, it is absent in case of the atrial fibrillation. Whereas in case of the heart block or in case of complete heart block, just now we have discussed, there will be presence of the 𝐾𝐽 wave. Then in case of the tricuspid regurgitation, see, there are three important abnormal JVP waves in tricuspid regurgitation. Number one, you will notice that there is reversal of the X wave in the tricuspid regurgitation, and you will have the presence of the tall V wave, or V wave amplitude is increased in case of tricuspid regurgitation. And the next very important point is you will have early Y descent. So these are the three important JVP changes that you will have in patients with the tricuspid regurgitation. Okay, so for this question, the A wave is absent in case of the atrial fibrillation, right? The next question. 𝐾𝐽 waves are seen in, okay, it's a repeat question again, the atrial fibrillation, junctional tachycardia, constrictive pericarditis, cardiac tamponade. So the 𝐾𝐽 waves, they are seen in patients with the junctional tachycardia, and you will have regular 𝐾𝐽 wave in case of junctional tachycardia. So atrial fibrillation, the A waves, they are absent, right? A waves are absent. Okay, and in case of constrictive pericarditis, these patients, they will have prominent X and as well as Y descent, right? Prominent X and as well as Y descent. And in case of cardiac tamponade, you will observe that you will have prominent X wave and Y wave is absent, right? Y wave is absent. Okay, so that is about your cardiac tamponade. So in the options, the answer is the junctional tachycardia. Next question. Giant A wave in JVP occurs in all of the following conditions except. The options are junctional rhythm, pulmonary hypertension, tricuspid regurgitation, complete heart block. Okay, so you take the giant A wave. You get this in 4 conditions. One is 2 conditions where you have the inflow obstruction of the right ventricle, right? That is right ventricular inflow obstruction. And you have 2 right ventricular outflow obstructions, right? What are those? So if you take the right ventricular inflow obstruction, that will be tricuspid stenosis and as well as the right atrial myxoma. Whereas what are the conditions like where right ventricular outflow obstructions where the giant A wave will be there is pulmonary stenosis, and the next one is the pulmonary hypertension. All right, so pulmonary hypertension you will definitely have. Next, in case of junctional rhythm and complete heart block, actually you will have the 𝐾non A wave. But in early stages of junctional rhythm and complete heart block, you will have giant A wave, then followed by that they'll have 𝐾non A wave. So occurs in all except is what? That is tricuspid regurgitation. You don't have the giant A wave. Next question. Okay, so 10th question is a repeat question. C wave in JVP indicates atrial contraction, bulging of the tricuspid valve cusp, ventricular systole, and then rapid ventricular filling. So C wave in JVP, it indicates the bulging of the tricuspid valve cusp. So after the questions of the JVP, next we have the questions on the aortic dissection. The investigation of choice for aortic dissection with hypotension is, see, actually in case of the chronic aortic dissection, MR aortography, right, that would be the best investigation. But MR, so definitely it is like the time taking procedure. So these patients are having hypotension. So in cases of hypotension, we cannot do MRI. So the options are CT scan, technetium 99 scan, MRI, transesophageal echocardiography. So the answer is the transesophageal echocardiography. See, the diagnosis of the aortic dissection can be established by non-invasive techniques like your echocardiography, CT, and as well as MRI. So that is the reason why the invasive investigation, right, invasive investigation, that is aortography, it is used less commonly because of the accuracy of these non-invasive investigations like echocardiography, CT, and as well as MRI. But out of which you take the transthoracic echocardiography. Transthoracic echocardiography, the sensitivity is around 60 to 85% is the sensitivity in transthoracic echocardiography. And this transthoracic echocardiography, it is useful mainly for diagnosis of the proximal aortic dissections. Right, it is useful mainly for the diagnosis of the proximal aortic dissections of the aorta. Whereas transesophageal echocardiography, it will be helpful for not only proximal aortic dissections, dissections in the aorta, ascending aorta, dissections in the arch, and dissections in the descending aorta as well. Okay, and transesophageal echocardiography, if you take the sensitivity and as well as specificity, so 98% is the sensitivity of the transesophageal echocardiography in diagnosing aortic dissections, but specificity is only 90%. Okay, so mainly these patients is having hypotension, so that is the reason why the preferable investigation is transesophageal echocardiography. Next question. All of the following factors predispose to aortic dissection except systemic hypertension, coarctation of aorta, first trimester of pregnancy, Takayasu arthritis. So what is the most common risk factor responsible for aortic dissection is systemic hypertension. Coarctation of aorta can also cause aortic dissection. Takayasu arthritis and even giant cell arthritis can also cause the aortic dissection. But the aortic dissection is not seen in the first trimester of pregnancy. It is observed in third trimester of the pregnancy. And what are the other connective tissue disorders that can predispose to your aortic dissection is, like that includes Marfan's, right? Then followed by that Ehlers-Danlos syndrome, and then osteogenesis imperfecta. So these are the conditions where you have the presence of the aortic dissection. Next. Right, rod spots are seen in the leukemia, uveal melanoma, starvation, aortic dissection. So what exactly are the Roth spots? They are retinal hemorrhages, right? And commonly you see these Roth spots in the infective endocarditis. The other conditions where you will come across is hypertension, then in case of diabetes mellitus, and you will also see in patients with leukemia, and you will also come across this in patients with anemia, right? And you will also come across this in patients with the polyarthritis nodosa and as well as the systemic lupus erythematosus. So these are all the conditions where you have the presence of Roth spots. So the answer in this question is the leukemia, right? So they are basically the retinal hemorrhages. Next question. Infective endocarditis is most commonly seen in ASD, VSD, patent ductus arteriosus, pulmonary regurgitation or pulmonary pathologies. So the infective endocarditis, right, most commonly is seen wherever there is high pressure gradient. Among the options which has been given to you, the high pressure gradient is seen in case across the ventricular septal defect. So please remember, in case of children, the most commonly associated risk for the development of the infective endocarditis is VSD, whereas you take in adults, right? So in the adults, the highest incidence of the infective endocarditis, it is seen across the mitral regurgitant lesions. It is seen across the mitral regurgitant lesions. Whereas in the ASD, the development of infective endocarditis, it is least common. Right? Least common. Okay. And the patent ductus arteriosus, they are the high risk lesions for the development of infective endocarditis. Next question. Which of the following is not true about infective endocarditis? Hematuria, rose spots, splinter hemorrhages, hemiplegia. So many of you have made a mistake by reading this rose spots as the Roth spots. Okay. So in infective endocarditis, you don't have the rose spots. What you have is the Roth spots that you will have in patients with the infective endocarditis. Now in patients with infective endocarditis, why there will be development of hematuria is there will be development of glomerulonephritis. In case of infective endocarditis, that can lead to hematuria. Splinter hemorrhages are observed in the nails of patients with infective endocarditis. Hemiplegia is also observed because of embolization of the vegetation into the cerebral circulation. And where do you see these rose spots? Rose spots, they are seen in 1/3 cases of the typhoid fever, right? So in case of the typhoid fever, you have the presence of this rose spots, okay? And these particular rose spots, right, they appear as rash between 7th, right, between 7th and 12th day, right, between 7th and 12th day from the onset of the symptoms, you have the presence of these particular rose spots. And whenever the individual develops the rose spots, they occur in groups, right? So how many lesions will be there? They are around 5 to 10 lesions, right? They are around 5 to 10 lesions. And where are these observed? These are observed over the lower chest, right? These are observed over the lower chest. And they are also distributed over the, right, they are also distributed over the upper abdomen. And whenever they appear, they will be there for nearly around 3 to 4 days. They last for nearly around 3 to 4 days. Okay, right. So this is about your rose spots. Next question. Most common causative agent for the infective endocarditis: Staphylococcus aureus, Strep viridans, Strep pyogenes, Strep mutilans. So in case of your infective endocarditis, the most common organism is the Staphylococcus aureus. So this Staphylococcus aureus, it is a highly virulent organism, right? And this particular Staphylococcus aureus, please remember, it is responsible for acute infective endocarditis where there is involvement of the native valves. So it is not previously involved or pathological valves. It is the native valves which are affected in patients with the acute infective endocarditis, and it's a highly virulent organism. So this table is very important regarding the organisms. So the community acquired or the native valve endocarditis, the most common organism, either it is community acquired or healthcare associated. It is your Staphylococcus aureus. Okay, then you take prosthetic valve endocarditis up to 1 year. The most common organism will be coagulase negative staphylococci, which is nothing but your Staphylococci epidermidis, right? And more than 12 months, this will become the streptococci or strep viridans. And the intravenous drug abusers, right-sided valves, the most common organism is Staphylococcus aureus. Left-sided valves, the most common organism is Enterococci. And overall, the most common organism will be your Staphylococcus aureus. Okay, next question. Infective endocarditis, where lifelong treatment is required. Aspergillus endocarditis, Liebman-Sachs endocarditis, Fusarium solani, then Enterococci. So please remember, it is the fungal endocarditis where lifelong treatment is very much required. And for the development of the fungal endocarditis, the most common organism will be Aspergillus, and the next important organism will be Candida. So in patients with the fungal endocarditis, they require surgical debridement of the abscess, right? And followed by the surgical debridement, you also need to start the medical management, right? You also need to start the medical management. So in the medical management, like you need to give the antifungal therapy, right? And what is that antifungal therapy that we give is liposomal amphotericin B, right? With or without the supplementation of the 𝐸𝐵, right? With or without the supplementation of the 𝐸𝐵. Okay, so these particular drug, liposomal amphotericin B plus 𝐸𝐵, they have to be given for nearly around 6 to 8 weeks, right? They have to be given for nearly around 6 to 8 weeks. Okay, then the next very important point you need to know is after this 6 to 8 weeks, the drugs that you need to give in these patients will be fluconazole, right? The drugs that is required is the fluconazole. Okay, so that is about the treatment of the infective endocarditis. So these patients with the, fungal endocarditis, they require lifelong treatment because there is increased chances of recurrence. Next question. Infective endocarditis is least common in mitral stenosis, the aortic stenosis, ventricular septal defect, atrial septal defect. So wherever is the pressure gradient less, then in such lesions or across that particular lesions, there is lesser chances of infective endocarditis, that is the atrial septal defect. So among the options which has been given to you, across the ASD, the pressure gradient is less, so the infective endocarditis is also least common. Next question. Least common site for vegetation is, okay, it's almost like a repeat question: aortic stenosis, mitral regurgitation, and then atrial septal defect. So the answer is the atrial septal defect, but let me tell you a few more additional points here. So the aortic stenosis and as well as mitral regurgitation, both of them, these are the high risk lesions for the development of the infective endocarditis, right? Whereas the mitral stenosis, that will be the moderate risk lesions. So except for the aortic stenosis, the other stenotic lesions like mitral stenosis, tricuspid stenosis, and pulmonary stenosis, all of them are the moderate risk lesions for the development of infective endocarditis. Next question. Mitral valve vegetations do not usually embolize to lung, liver, spleen, brain. So mitral valve vegetations do not usually embolize to the lung. See, why they do not embolize into the lung is, in order to have the embolization into the lung, there should be backward flow of the blood, right? There should be backward flow of the blood. So in patients with your infective endocarditis, you don't have a backward flow, right? What is that you have is the forward flow, right? From the heart, the blood moves into the aorta and so on to the organs. So in order to have the lung involvement, there should be backward flow of the blood from the heart into the lungs. Okay, so that is the reason why the lung involvement is least common, whereas liver, spleen, brain, they commonly can get affected. So next question. Most common heart valve involved in IV drug abusers: mitral valve, aortic valve, pulmonary valve, and tricuspid valve. So the intravenous system or the venous system, it is connected to the right side of the heart, and within the right side, the valve that appears first once the venous return comes is the tricuspid valve. So that is the reason why any organism which is coming through the intravenous route, that gets first accommodated over the tricuspid valve, where the tricuspid valve endocarditis is more common. Okay, next question. A patient with prosthetic heart valves develop endocarditis 8 months after the valve replacement. So most likely organism responsible is Staph aureus, Staph epidermidis, Strep viridans has a group of organisms. So just now I was discussing in the table also, in case of the prosthetic valve endocarditis, right, up to 12 months, the most common organism will be your Staphylococcus epidermidis, and it is after 12 months your Strep viridans is most common. Right, after 12 months the Strep viridans is most common. Okay, next question. Caricombs murmur is seen in, the options are the severe mitral stenosis, acute rheumatic carditis, pure aortic regurgitation, severe pulmonary hypertension. Now, Caricombs murmur, what exactly is this? Caricombs murmur, it is a functional murmur and it's a mid-diastolic murmur. And you see that in patients with acute rheumatic carditis. So in case of this acute rheumatic carditis, there will be development of the acute mitral regurgitation. There will be development of acute mitral regurgitation. Okay, so this acute mitral regurgitation, actually you get the true murmur as the early systolic murmur, right? The true murmur will be the early systolic murmur, and followed by this early systolic murmur you get a functional murmur which is a mid-diastolic murmur, that is nothing but Caricombs murmur, and it's a low pitched murmur. Okay, next question. In case of the streptococcal pharyngitis, how early should the treatment be initiated to effectively prevent the rheumatic fever? 7 days, 8 days, 9 days, 10 days. Okay, so it is like the answer based on the various studies which have been done in various populations. So the answer is 9 days. So if you start the treatment for streptococcal pharyngitis within 9 days of the onset, then you can effectively prevent the development of rheumatic fever. Next question. Which among the following is not common in rheumatic heart disease? MS, AS, pulmonary stenosis and tricuspid stenosis. So in case of rheumatic heart disease, the most common valve affected is the mitral valve, followed by that the aortic valve, and followed by that there will be involvement of the tricuspid valve, and last and least commonly affected valve will be the tricuspid, the pulmonary valve. So pulmonic stenosis, it is not common in case of the rheumatic heart disease. Next question. Sequelae of rheumatic heart disease in a 5-year-old child is mitral regurgitation, mitral stenosis, tricuspid stenosis, tricuspid regurgitation. So sequelae of rheumatic heart disease in a 5-year-old child is, please remember, in children, right? In children, the most common valvular lesion that you come across in patients with rheumatic fever will be mitral regurgitation. Now, what is the reason for the mitral regurgitation in children is, in rheumatic heart disease, the damage to the chordae tendineae by inflammatory Aschoff nodules result in the development of mitral regurgitation in pediatric presentation. Whereas age of the individual more than 8 years, the most common valvular lesion will be mitral stenosis. Okay, so the answer in this question is the mitral regurgitations, because specifically asked in a 5-year-old child. Okay, next question. Which of the following is the minor criteria for the diagnosis of rheumatic fever according to modified Jones criteria? The options are the ASO titer, past history of rheumatic fever, and presence of fever and subcutaneous nodules. So you take the minor criteria. Minor criteria, that is like modified Jones criteria, what all will be there is fever, right, where temperature more than 38 degrees centigrade, then PR interval being prolonged, then ESR and CRP being increased. So the presence of the fever, that will be the minor criteria for the diagnosis of rheumatic fever. Next question. Diagnostic feature in rheumatic heart disease is the Aschoff nodules, McCollum patch, pancarditis, then fibrinoid necrosis. So please remember the diagnostic feature in rheumatic heart disease, that will be the Aschoff nodules. Okay, so these Aschoff nodules in case of rheumatic fever, they are present in all the three layers of the heart. That is, they are present in endocardium, myocardium, and as well as pericardium. McCollum patch, right, it is only the endocardial involvement. Right, it is only the endocardial involvement, whereas the Aschoff nodules, they are present in all the three layers. And in patients with rheumatic heart disease, the carditis that you will have is pancarditis, but your pancarditis can be seen in multiple other conditions also. So that is the reason why the presence of Aschoff nodules in all these three layers, that is what is very much diagnostic for your rheumatic fever. Next question. The earliest valvular lesion in case of acute rheumatic fever: mitral regurgitation, aortic regurgitation, mitral stenosis, aortic stenosis. So in case of the acute rheumatic fever, the earliest valvular lesion will be mitral regurgitation, whereas in case of the chronic rheumatic heart disease, the most common valvular lesion will be mitral stenosis. Now, after this mitral valve pathology, the next will be your aortic valve pathology in the form of either aortic regurgitation or aortic stenosis, followed by the tricuspid valve pathologies, that is tricuspid stenosis or tricuspid regurgitation. And pulmonary valve involvement is least common or does not occur in patients with the rheumatic fever. Next question. The site of lesion in endocarditis of rheumatic heart disease is along lines of closure, both sides of the valves, valve cusps, free margins of the valves. So please remember, the site of lesion in endocarditis of rheumatic heart disease will be along the lines of closure, right? And that can cause the mitral stenosis. So this is about the questions related to the medicine challenge number 8. Okay, so now see you again in the medicine challenge number 9. Thank you very much.